Neonatal jaundice. In this chapter, we will read about neonatal jaundice. Jaundice is a yellowish discoloration of skin and sclera. About 60% of the term and 80% of the preterm neonates are clinically jaundiced. However, jaundice in the newborn might signal a serious, potentially treatable illness and may cause neurological damage if the bilirubin level is significantly elevated. Now, what are the learning objectives of this chapter? The participant, after completing this chapter, should be able to enumerate the characteristics of physiological jaundice, enumerate the characteristics of pathological jaundice and alert signs, assess the severity of jaundice based on the clinical estimation, institute phototherapy based on recommended guidelines, assess a neonate with conjugated hyperbilirubinemia. Let's see what are the classical patterns of physiological jaundice. All of the following are physiological jaundice. Jaundice that appears between 24 to 72 hours of the age, that is physiological. Maximum intensity is seen on the 3rd day in the term and 7th day in the preterm neonates, that is neonatal jaundice. Does not exceed 15 mg per deciliter. Clinically undetectable after 14 days. Jaundice is not detectable after 14 days. Okay. And no treatment is required, but the baby should be observed closely for the signs of worsening jaundice. Okay, this is the physiological jaundice. Alert signs in the neonatal jaundice or the pathological jaundice, any of the following. Clinical jaundice in the first 24 hours if present, then that is a pathological jaundice. Total serum bilirubin increasing by more than 5 mg per deciliter or 0.3 mg per deciliter per hour in the first 24 hours and 0.2 mg per deciliter per hour later. So in the first 22 hours it is 0.3, okay, and in the later hours it is 0.2 mg per deciliter per hour. And total serum bilirubin or per day it is more than 5. That is, the total serum bilirubin is increasing by more than 5. Total serum bilirubin of more than 15 mg per deciliter, staining of the palms and soles. Conjugated serum bilirubin of more than 1 mg per deciliter, that is also pathological if the conjugated serum bilirubin is more than 1 mg per deciliter. And fifth one is clinical jaundice persisting for more than 2 weeks in a full term and more than 3 weeks in a preterm. So if any jaundice is persisting beyond 3 weeks, that is pathological jaundice. Okay, that is beyond 3 weeks, beyond 20 days after birth. Now, what are the causes of jaundice? Hyperbilirubinemia in the first week of life is usually of unconjugated variety. Conjugated hyperbilirubinemia, or the direct one, although occurs less commonly but is always pathological. Causes are usually classified based on the time of the onset of jaundice. If it is appearing within 24 hours, then it may be of hemolytic disease of the newborn like RH or ABO incompatibility and the minor group incompatibility. Infections like the intrauterine, viral, bacterial or malaria, and G6PD deficiency. So these occur within 24 hours. Fine, hemolytic disease in that include incompatibility, infections and G6PD deficiency. Jaundice appearing after 24 hours of the life, it can be all the above that we read, plus physiological polycythemia, concealed hemorrhage like cephalhematoma and subarachnoid bleed or intravascular hemorrhage. All these can cause jaundice. And suboptimal breastfeeding, that is less than required breastfeeding, sepsis, neonatal hepatitis and metabolic disorders. All these can cause jaundice which appears after 24 hours of life. Persistent jaundice causes can be ongoing hemolysis in the blood group incompatibility, congenital hypothyroidism, liver disorder, sepsis, hereditary blood disorders like the hereditary spherocytosis, G6PD deficiency, pyruvate kinase deficiency, any malrotation or atrasias. So they can present early. These kind of blood disorders like hereditary spherocytosis, G6PD deficiency and the pyruvate kinase deficiency, they present early. Starting with clinical assessment of jaundice neonate. In the assessment of jaundice neonate, the history and the examination are directed towards assessing the etiology, severity and complications of the jaundice. When a neonate is clinically jaundiced, the total serum bilirubin is usually more than 5 to 7 milligram per deciliter. Jaundice in the newborn progress in cephalocaudal direction, and thus the extent of yellowness of the skin is useful to assess the level of bilirubin. There is a Kramer's criteria which is used to clinically estimate the severity. If the jaundice is restricted to face and trunk, then the serum bilirubin is less than 12 milligram percent, and if it's on the hands and feet, then it is more than 15 mg percent. Once the baby is under phototherapy, these assessment may be incorrect. Transcutaneous bilirubin estimation is better to assess the jaundice clinically. This is the visual perception of the jaundice. So if the bilirubin is jaundice is present till face, it may be around 6, bilirubin may be around 6. If up to trunk, then bilirubin may be around 9. If up to thighs and lower limbs, it's reaching the lower limb, then it may be around 12. And if reaching the soles, jaundice is reaching till soles, then it may be around 15 or 18 to 20. Now, how do we approach a jaundice baby? We need to follow the following question need to be addressed. What is the gestation? What is the birth weight and the current weight? What is the postnatal age in hours? Baby need any evaluation for jaundice? Baby need phototherapy or the exchange transfusion? Does the baby have any risk factors for the bilirubin neurotoxicity? And does the baby have features of encephalopathy? Features of acute bilirubin encephalopathy. Hypotonia, lethargy, high-pitched cry, poor suck, hypertonia of the extensor muscle, irritability, fever, seizures, opisthotonus, shrill cry, apnea, coma and death. These all are the features of acute bilirubin encephalopathy, and this is very important to remember. The baby will be very hypotonic, the baby will be lethargic, the baby will have a high-pitched cry, poor suck, hypertonia of the extensor muscles, there will be irritability, fever, seizures, opisthotonus, shrill cry, apnea, coma and death. Now coming to the evaluation, all the babies visibly jaundiced below the knees should have a blood sample for total serum bilirubin estimation. Plot the values on the AAAP charts on the bilirubin nomograms and decide the intervention. Please ensure that the decisions are based on the estimation of the total serum bilirubin value only. Total serum bilirubin may be estimated by transcutaneous bilirubinometer. Also, TSB should be measured if the TCB exceeds or is within 3 mg per deciliter of the phototherapy treatment threshold, or if the transcutaneous bilirubin is more than 15 mg per deciliter. Babies needing phototherapy should have a jaundice workup. We have to do the hemoglobin, the retic count, the peripheral smear for the evidence of hemolysis, blood group of the mother and the baby, G6PD, DCT and the TSH. Save baby and the mother's blood sample for the cross matching. For 35 weeks or higher. Management of the jaundice is directed towards reducing the bilirubin and preventing the CNS toxicity. That's what we want to do, right? We want to reduce the levels of bilirubin and we want to prevent the CNS toxicity. So, prevention of hyperbilirubinemia by early and frequent feeding. Okay. Also, we have to identify the predisposing risk factor for the significant hyperbilirubinemia. We have to identify the risk factor. Also, if there is jaundice, identify the risk factors for hyperbilirubinemia associated neurotoxicity. Now, for reduction of bilirubin, this is achieved by phototherapy or exchange transfusion, and the decision to treat depends on the severity and the cause of jaundice. Risk factors for developing significant hyperbilirubinemia. These are all the risk factors. Fine. First one is the lower gestational age. That is, the risk increases with each week less than 40 weeks. Jaundice in the first 24 hours after the birth. If jaundice is appearing within the first 24 hours, that means it is pathological, and pathological jaundice, the bilirubin can rise more than 15, causing hyperbilirubinemia. Severe hyperbilirubinemia, I would say. And pre-discharge transcutaneous bilirubin or total serum bilirubin concentration close to phototherapy threshold. Hemolysis from any cause, if known or suspected, based on the rapid rate of increase in the TSB, that is serum bilirubin or the transcutaneous bilirubin, of more than 0.3 mg per deciliter per hour in the first 24 hours, or more than 0.2 mg per deciliter per hour, therefore thereafter. So this is the rate of increase of this bilirubin. Okay, in the first 24 it is more than 0.3, and then in the later hours it is more than 0.2 per hour thereafter. Phototherapy before discharge. Parent or the sibling requiring phototherapy or exchange transfusion, if there is any history of this, then there can be chances that the newborn also requires the exchange transfusion or phototherapy. Family history of any genetic ancestry suggestive of inherited red blood cell disorders, including glucose 6-phosphate dehydrogenase deficiency. Okay. Exclusive breastfeeding with the suboptimal intake. The baby is not taking proper breastfeeding, then also it can cause significant hyperbilirubinemia. Scalp hematoma or significant bruising if present. Down syndrome. Macrosomic infant of a diabetic mother. All these are risk factors for developing significant hyperbilirubinemia. Now, hyperbilirubinemia, neurotoxicity risk factors. What are the risk factors that will cause hyperbilirubinemia, will cause neurotoxicity? First one is gestational age of less than 38 weeks, and this increases the risk with a degree of prematurity. Albumin if less than 3 gram per deciliter, then it can also cause neurotoxicity. Chances of neurotoxicity increases. Isoimmune hemolytic disease like the positive direct antiglobulin test, G6PD deficiency, or other hemolytic conditions. Sepsis, significant clinical instability in the previous 24 hours. Fine, so these are all hyperbilirubinemia risk factors. The decision to treat with phototherapy or exchange transfusion will depend upon the total bilirubin levels plotted on the charts given in this figure 12.2 to 12.5 given below as per the gestational age, the age of the newborn in hours, and the associated neurotoxicity risk factors mentioned in the table 12.2 that we just read, right? So this is a chart in which what is given: phototherapy threshold by gestational age and hours for the infants with no recognized hyperbilirubinemia, neurotoxicity risk factors, and other gestational age. Other than gestational age, okay. So these are all the phototherapy thresholds. We have to calculate. We have to plot by the day, okay, and also it is given in hours also. And now we have to follow the weeks. Suppose there is a baby of 6th day, and let's take an example. 6th day. In fact, we should take initial days. Suppose second day, and bilirubin of 17, and the baby was born on 37 weeks. Let's plot this graph and see where it comes. See, on plotting the graph, it comes around here. Okay, you just have to mark a point. So this is coming and 37 weeks is demonstrated by this line. So this is coming above that line. That's why it is coming under the phototherapy range. Okay. This graph is followed if there is no hyperbilirubinemia, neurotoxicity risk factors. If one or more hyperbilirubinemia, neurotoxicity risk factors, then we have to follow this graph. And if no exchange transfusion threshold, no hyperbilirubinemia, neurotoxicity risk factors, and exchange transfusion with one or more hyperbilirubinemia, neurotoxicity risk factors. And all the risk factors we read here. There is a gestational age of less than 38 weeks, albumin of less than 3 gram per deciliter, isoimmune hemolytic disease, sepsis, or significant clinical instability in the previous 24 hours. Fine. Now moving ahead, they drill on the use of charts. The facilitator now will, this is not done. This don't need to be done in this video. For less than 35 weeks and birth weight of less than 2000 grams. For less than 35 weeks and birth weight of less than 2000 grams. Guidelines to treat hyperbilirubinemia in preterm neonates. So if a baby is less than 1000 grams and the bilirubin is between 5 to 7, then we have to give phototherapy. And the baby is healthy infant. Guidelines for again phototherapy: if between 4 to 6 bilirubin, and if the bilirubin is between 10 to 12, then we have to consider for exchange transfusion. Like that, we have to follow through these also. Neonates with a gestational age at birth of less than 35 weeks and birth weight of less than 2000 grams and the onset of jaundice at less than 60 hours of postnatal age are at higher risk. Coming to the follow-up. A follow-up plan may be devised based on the pre-discharge bilirubin level and timing of the discharge neonates. So, start. Transcutaneous bilirubin or the total serum bilirubin measure in infant more than 12 hours old. We have to determine the hour-specific phototherapy threshold based on the gestational age and the presence of known hyperbilirubinemia and neurotoxic risk factor from the table. Then we have to measure the total serum bilirubin, or if the transcutaneous bilirubin exceeds 3 mg per deciliter below the phototherapy treatment threshold, or if the transcutaneous bilirubin is more than 15 mg per deciliter. Total serum bilirubin at or above the phototherapy threshold. If present, then we have to begin the phototherapy, and if the total serum bilirubin is not above the phototherapy threshold, then what we have to do? In age less than 24 hours, if it is between 1.1 to 1.9, then we have to delay the discharge, consider phototherapy, and measure the total serum bilirubin in 4 to 8 hours. If the age is more than 24 hours, measure the total serum bilirubin in 4 to 24 hours. Option: delay the discharge and consider phototherapy in these children, right? That if the total serum bilirubin is 0.1 to 1.9, then this is what we have to do, and age is more than 24 hours. We can either delay the discharge, we can discharge without phototherapy if all the considerations in the guidelines are met, and discharge with phototherapy but close follow-up. Fine. And if the bilirubin is between, this was the first thing that we saw, that is between up to 1.9. If the bilirubin is 2 to 3.4, regardless of the age at the discharge, we have to do total serum bilirubin and total transcutaneous bilirubin in 4 to 24 hours. Fine. If the bilirubin is between 3.5 to 5.4, then regardless of age at the time of discharge, we have to do total serum bilirubin and transcutaneous bilirubin in 1 to 2 days. If the total serum bilirubin is 5.5 to 6.9, discharging in less than 72 hours, that is less than 3 days, then we have to follow within 2 days, or transcutaneous bilirubin or total serum bilirubin according to the clinical judgment. And if discharging by more than 48 hours, then again the clinical judgment. And if it is more than 7 and we are discharging the patient, discharging less than 72 hours, then follow up within 3 days, to transcutaneous bilirubin, total serum bilirubin according to the clinical judgment, and discharging more than 72 hours, then again clinical judgment. Flow diagram for the infants. This, whatever we read right now, was the flow diagram for the infants during the birth hospitalization to determine the post-discharge follow-up for an infant who have not received phototherapy. Coming to exchange transfusion now. It is an effective and reliable method to reduce the serum bilirubin. It should be performed if the total serum bilirubin remains in the exchange transfusion range as per the charts despite effective phototherapy. Immediate exchange transfusion is indicated if the features of bilirubin encephalopathy are evident. Fine. When is immediate exchange transfusion indicated? If the features of bilirubin encephalopathy are present. If facilities for exchange transfusion are not available at your center, early referral to a higher center is indicated. Delay in the treatment may result in the permanent brain damage. If the facilities are not available at your center for exchange transfusion, then the early referral to higher center is indicated. Delay in the treatment may result in permanent brain damage. However, if the facilities and the skills for performing the exchange transfusion are available, the same can be done. While referring a baby with the jaundice, make sure that the mother accompanies the baby. In case this is not possible, the mother's blood sample should be sent along with the baby. Type and the volume of the blood. For RH isoimmunization, the best choice would be O negative packed cells. Type and the volume of the blood for RH isoimmunization, the best choice would be O negative packed cell suspended in AB positive plasma. O negative whole blood or the cross-matched baby's blood group may also be used. For ABO isoimmunization, O group, packed cell suspended in AB plasma or the O group, whole blood RH compatible with the baby should be used. In other situation, the baby's blood group should be used. All the blood must be cross-matched against the maternal plasma. Now coming to the conjugated hyperbilirubinemia. This is rare in newborn period and is defined as steric bilirubin of more than 1 mg per deciliter when the total serum bilirubin is less than 5, or more than 20% of the total serum bilirubin if the total serum bilirubin is more than 5 mg per dl. Fine, this is very important to remember that when do we call conjugated hyperbilirubinemia. If direct bilirubin is more than 1 mg per deciliter, when the total serum bilirubin is less than 5 mg per deciliter, and more than 20% of the total serum bilirubin total serum bilirubin more than 5 mg per deciliter. It is important to document a cause as it is never physiological. Approach, what is the approach of this? The following four questions need to be answered. Is the baby small for gestational age? Is the stool white or clay colored? Is the urine high colored? Are liver and spleen enlarged? Never discharge a baby with conjugated hyperbilirubinemia without attempting to find the cause. Rule out or establish the diagnosis of extrahepatic biliary atresia. We have to rule out or establish the extrahepatic biliary atresia within 8 weeks of the life till it is still surgically correctable. These babies are preferably managed in a level 3 neonatal unit. Give IV injection vitamin K and refer to higher center. Rule out the congenital hypothyroidism and underlying sepsis. Fine. We have to do what? We have to rule out the congenital hypothyroidism and underlying sepsis. Use of phototherapy will be explained in the equipment section. Now, when to refer? We should know when to refer. Baby requiring exchange transfusion and the facility does not has that. Baby with the persistent jaundice for the further workup, and baby with the conjugated hyperbilirubinemia for workup and management. This is all about this video. Let's revise in the fastest way possible. Only the things that we have marked. We'll go through that only. Fine, the classical pattern of physiological jaundice. When we have to call physiological jaundice, when it is appearing between 24 to 72 hours and maximum intensity seen in the 3rd day in term and 7th day in the preterm, does not exceed 15 mg per deciliter, clinically undetectable after 14 days, and no treatment is required, but the baby should be observed closely for the signs of worsening jaundice. Clinical jaundice in the first 24 hours of life. Total serum bilirubin increasing by more than 5 mg per deciliter or 0.3 mg per deciliter per hour in the first 24 hours and 0.2 mg per deciliter per hour later. This is how at this rate, if the serum bilirubin is increasing, then it is pathological. If the total serum bilirubin is more than 50 mg per dl, then also it's pathological, that is staining the palms and soles. Conjugated serum bilirubin of more than 1 mg per dl, because conjugated is never physiological. We just read, right? It is always pathological. And clinical jaundice persisting for more than 2 weeks in full term and more than 3 weeks in preterm, that is pathological jaundice. We read about the causes of jaundice, and some blood disorders that can present cause persistent jaundice are the hereditary spherocytosis, G6PD deficiency, pyruvate kinase deficiency. Clinical assessment of a jaundice neonate, that is total serum bilirubin is usually more than 5 to 7 mg per deciliter. Fine. Face and trunk, if appearing jaundice is appearing till there, then the serum bilirubin is less than 12, and if the serum bilirubin jaundice is restricted to hands and feet, then the serum bilirubin is more than 15 mg%. Features of the acute bilirubin encephalopathy, this is very important to monitor: hypotonia, lethargy, high-pitched cry, poor suck, hypertonia of the extensor muscles, irritability, fever, seizures, opisthotonous cry, apnea, coma and death. These are all the jaundice workup that we need to do: hemoglobin, retic count, PS, blood group of the mother and the baby, G6PD, direct Coombs test, and the TSH. Now for management, and for 35 weeks or higher, our main aim is to reduce the level of bilirubin and prevent CNS toxicity. So we have to start early feeding and frequent feeding to prevent hyperbilirubinemia. We have to identify any predisposing risk factor if present. Fine, and we have to if there is jaundice, we have to identify the risk factor for the hyperbilirubinemia associated neurotoxicity. Also, reduction of bilirubin. This is achieved by phototherapy and exchange transfusion. These were all the risk factors for developing significant hyperbilirubinemia. Who will develop significant hyperbilirubinemia? Lower gestational age, jaundice within 24 hours, serum bilirubin or the transcutaneous bilirubin close to phototherapy threshold, hemolysis if from any cause if suspected based on the rapid rate of increase in the total serum bilirubin or transcutaneous bilirubin, phototherapy before discharge, parent or sibling requiring phototherapy or exchange transfusion. Fine, exclusive breastfeeding with suboptimal intake, scalp hematoma also can present with significant hyperbilirubinemia, Down syndrome or macrosomic infant of a diabetic mother. And these are all the hyperbilirubinemia neurotoxicity risk factor. This is also very important. Gestational age of less than 38 weeks, and this risk increases with the degree of prematurity. Albumin less than 3 gram per deciliter, isoimmune hemolytic disease, sepsis, and significant clinical instability. These are all the risk factors for hyperbilirubinemia neurotoxicity, that is hyperbilirubin, increase in the bilirubin levels causing any neurotoxic symptoms. These are all the charts to determine what the baby needs right now, either phototherapy or exchange transfusion. This is what we have to these are all the discharge recommendation, that in how many days we have to ask the patient for follow-up. And this was all about the exchange transfusion. Immediate exchange transfusion is indicated in features if bilirubin encephalopathy features are present, conjugated hyperbilirubinemia, that is direct bilirubin level of more than 1 mg per deciliter when the total serum bilirubin is less than 5 mg per deciliter, and more than 20% of the total serum bilirubin is 5 mg per deciliter. What is written here? It is not confusing at all. If the serum bilirubin is less than 5 mg per deciliter, then if the direct bilirubin is more than 1 mg per deciliter, then that is called as conjugated hyperbilirubinemia. And if the total serum bilirubin is more than 5 mg per deciliter, suppose it is 16, in that case, if the direct bilirubin is more than 20% of 16, that is 3.2. So the direct bilirubin is more than 3.2. In this case, then it will be called as the conjugated hyperbilirubinemia. Fine. Also in conjugated, we have to find out the cause. Extrahepatic biliary atresia we have to rule out, and we have to early diagnosis of extrahepatic biliary atresia to be done, because within 8 weeks of the life till it is surgically correctable, because it is surgically correctable only till 8 weeks of life. And if these babies are managed in level 3 neonatal unit, and if we have to give injection vitamin K and then refer to higher center if yours is not a tertiary care level. So this was all about hyperbilirubinemia and neonatal jaundice. Thank you.